about how to prevent spinal cord ischemia during thoracoabdominal aortic surgery as well as in TAAA. So I will tell about the predictors and the methods of preventing the spinal cord ischemia. So among all other complication in thoracoabdominal aneurysm repair, the most stressful is, I will say, it is because of paraplegia. It's more devastating because other things, there is some like if there is a renal failure or any bowel ischemia, limb ischemia, or DAC, those things, at least there is some kind of management we can do. But once the spinal cord ischemia happens, the patient develops paraplegia, nothing much we can do, and we shouldn't think this as an isolated single system involvement. Most of the time the spinal cord ischemia will go on to profound autonomic dysfunction, and most of these patients goes into multi-organ dysfunction, and mortality is very high in this patient. So in our like practice, only very few patients have survived after spinal cord ischemia. Usually spinal cord ischemia is a starting point, then slowly other system involvement will be there, and mostly mortality is like it ultimately results in mortality. So that's why this is most important, and then nothing much we can do once it happens. So we should know how to prevent rather than rescuing this patient. So the incidence is there both in open as well as endovascular repair, and definitely endovascular carries less risk of paraplegia, but definitely it's not negligible. You can see it has up to tune of more than 5%, and definitely the risk is more with the type of extent of the aneurysm. So type 2 being involving the both entire thoracic and abdominal aorta definitely carries high risk of paraplegia, and followed by type 1 and type 3. Type 5 and type 4 generally carries a less risk of paraplegia in these patients. So we should understand the blood supply of spinal cord. Sir, I am audible, no sir? I am just continuing without any.
Yeah, you can.
Yes, okay. The spinal cord blood supply is very important to understand what is the physiology behind it. So as we know, spinal cord has two blood supply. One is the anterior spinal artery, and then pair of posterior spinal artery. So the anterior 2/3 of the spinal cord is supplied by the anterior spinal cord and the anterior spinal artery, and posterior to 1/3 of the spinal cord is supplied by the posterior pair of posterior spinal arteries. So the anterior spinal artery supplies the motor. Motor area like spinothalamic cord. Yeah. So it supplies the motor area of the spinal cord. So that's why anterior spinal cord. We are more worried about the anterior spinal artery. And the other problem with the anterior spinal artery is it is not a continuous vessel, and often it is. Okay, so anterior spinal artery is not like a continuous arteries. In often it is discontinuous as we go beyond the mid or lower thoracic area, and it is often reinforced by the multiple other branches. So there are two concepts in spinal cord perfusion. One is anatomical concept, and another is a collateral network concept. The anatomical concept is the old one where it is purely based on there is three arteries are there, one spinal and two posterior spinal arteries. So one anterior and two posterior spinal arteries. So if we always have to save the anterior spinal artery, we have to reimplant the intercostal. That's otherwise the anterior spinal artery may not flow properly. But the collateral network concept, what they later on what they observed is the anterior spinal artery is very as it gets narrowed down, it gets reinforced by multiple other branches. So it starts from vertebral artery, then goes down all the intercostal, then lumbar and interiliac. So what the collateral concept says is like even though if we are sacrificing the thoracic intercostal vessel, if other systems like subclavian, vertebral and internal lumbar, internal iliacs are normal, we can internal iliacs are normal. We can this will collateral will improve and improve supply to the spinal cord. We no need to reimplant the spinal cord. We no need to reimplant routinely in all these cases. These are the two concepts. Both are acceptable, but mostly what we see is when there is adequate collateralization with other vessels, we no need to routinely reimplant this intercostal arteries. So there are various risk factors. This is common for both open as well as TAAA. So as most important is the extent, and definitely emergency surgery carries a more chance of paraplegia. And most important predictor during open surgery is the duration of aortic crossing. shorter the duration of aortic cross clamp, overall surgical results are very good, not only related to the spinal cord as well as the other viscerorenal perfusion. Everything improves, and the overall results are better if the shortest shortest duration of the cross clamp. And previously, if there is intercostal arteries are sacrificed, for example, in AAA repair or any other proximal TAAA or anything is done, then it carries a risk of paraplegia, and other these are the other factors. So we shouldn't think spinal cord ischemia as isolated as just we are clamping the vessel. I mean, we are closing the circulation. That's why it is crossing. But it is a both physiological thing also. Anatomically, even though we are closing of the intercostal arteries, there are other physiological process also happens. Mainly the ischemia and the reperfusion injury, and then other factors like anemia and hypoxia also adds to the intensity of the infection. So main thing, it starts with the clamping of aorta. So whatever happens is, once we aorta is clamped, the intracranial pressure increases, and then there is a CS pressure will be very high. At the same time, higher arterial flow to the spinal cord is coming down, so that decreases the overall ischemia of the spinal cord. And along with it, there are various neurotoxins are getting released. And once we reperfuse, once we finish the surgery, reperfusion also happens. Reperfusion increases the cord edema, so that also causes the extra insult to the spinal cord. These are the various factors which are affecting the causing the spinal cord ischemia. So our prevention is based on managing this one of these factors, either ischemia or the reperfusion. So there are two types of onset of spinal cord ischemia. Either it can be an immediate onset where the patient wakes up with the dense paraplegia. Other delayed is patient has woken up with the normal power and later on is developing. So the immediate onset is very poor prognostic type. It usually the already the insult has happened. It is actually the infarction has happened, and so that is very less likely to the patient will be improving. But delayed onset is mainly the perfusion is less, or ischemia is there, but it's not much infarction hasn't happened. So if you can improve the perfusion to spinal cord, this will improve. So basically, these patients, we keep the BP high and we keep the CSF pressure low, so the spinal perfusion will increase. And these patients are more likely to recover, and they don't present usually with the dense paraplegia. Only paraparesis will be there, and the recovery is more likely to happen in the delayed onset group. So these are the various 5-pronged strategies that we use. First is minimizing the ischemia time, then optimizing the perfusion, preserving the supply. When we have to detect early ischemia, and then increasing the tolerance to ischemia. Each has many methodologies. I'll go through one by one. So coming to first, minimizing spinal cord ischemia time. As I said, first most important is I have to keep the surgery as short as possible. As early as possible, if we can reperfuse the aorta, I mean perfusion, everything can be reached. So that is the most easiest, best method, but it's not often possible. And this is not, but TVAR, this one important step is not happening. That's why the TVAR carries less chance of paraplegia, because there is no final aortic cross clamping. Then during surgery, we have two options. One is we have to use any distal perfusion, other is sequential clamping. So distal perfusion is when we are clamping the aorta, unlike in infrarenal aorta, whenever you go above the celiac artery, most likely especially in the type 1, 2, and 3, if you without any distal perfusion, if you do clamp and sew, definitely there will be distal ischemia to not only the spinal cord but also to the viscerorenal and limb ischemia. So that increases high chance of viscerorenal dysfunction as well as paraplegia. So there's some kind of distal perfusion has to be used in thoracoabdominal aneurysms, especially in type 1, 2, 3. So what are the advantages? First of all, it reduces the visceral ischemia as well as spinal ischemia, and it reduces the afterload to the heart, and also reduces the ischemia to the limb. So we have two options. One is a passive shunt, one is active shunt. Passive shunt means it is like a carotid shunt where the blood is taken from the aorta above and below, and without any extra need of a pump or something. That is a very straightforward shunt. Other one is an active shunt where we use a pump to take the blood from above the clamp and give below the clamp. So most easiest one will be this passive shunt, initially described as a God shunt. What they do is, like if there is like for example here shown is there is a mid DT aneurysm, we take blood from above the clamp from the aorta and give below the clamp. So the original God shunt, whatever we described, is a heparinized tube. The tube is coated with heparin, so he didn't use any extra system heparinization. So those things are not available. We routinely what we use is some kind of custom-made tube that we use in our institute. So we put one cannula into the aorta above the clamp, and this will go to the femoral cannula. And if we need, from here we take blood for the celiac and SMA, and renal artery we give a renoplegia. So this is a passive shunt. Here what is happening is we are taking a blood from above and giving to below the clamp, but the flow is mainly based on the proximal beam. If you increase the proximal BP, automatically the flow to the distal vessels will increase. So main problem with this is unreliability. So the main way it is flowing is because of the BP difference. So if there is active loss during surgery, this BP we may not be able to bring it up. That's why the flow is very much unreliable. In that case, we can use active shunts. Active shunt is similar phenomenon. We are taking blood from above and giving to below the clamp, but instead of we are using extra pump, and then to the pump it is given actively to the femoral vessels. So here advantages, this is more reliable way of doing. So we know exactly how much we are taking from above, how much we are giving distally. Only problem with this active shunts is we have to give more heparin. So definitely the high chance of DAC is in that in these cases. So most commonly what we use is the left, femoral artery femoral vein bypass. So what we take is we take blood from the femoral vein, is given to the pump, it is oxygenated and given back to the femoral artery, and we'll be doing the surgery above this. And from here we can take blood for the celiac and SMA, and renal artery will give renoplegia. This is one form. Other one is left heart bypass. Left heart bypass, we take oxygenated blood from the left heart, either through the left atrium or the pulmonary vein. So basically we are taking oxygenated blood and giving back to the femoral artery or aorta. So you no need of any oxygenation or any extra warming or cooling. So the overall heparin is less in this left heart bypass. So both can be used based on the institute's preference. And next important step is sequential clamping. So usually what we do is whenever we start doing the repair, we don't clamp the aorta above and below the aneurysm and open the entire aneurysm. We try to do something called a sequential clamping. So first we try to clamp as much close to the proximal anastomosis, and distally we will start perfusion, so the distal it will be flowing, and then we slowly shift the clamp down to include the intercostal. Then we go for visceral, and then finally we open the full. Go for distal. So sequential clamping carries advantage. One is there is less loss of the blood from the aorta, as well as the intercostal keeps getting perfused during the sequential clamping. So this is how we do. But it is not possible always in all the cases, because here we are midway we are clamping the aneurysm. Sometimes aneurysm is so big it may not be able to be clamped, but whenever possible we try to do a sequential clamping. So here we have taken a left heart. This is a left heart bypass. Blood is being taken from the left heart from the inferior pulmonary vein and given back to the aorta, and we are clamping as much close to the above the aneurysm and as much close to the aneurysm, and we'll finish off the proximal anastomosis. So during this time, blood is getting aorta and intercostal viscerals are getting perfused, and there is not much backbeat from the intercostal. So overall, we'll have a bloodless field, and once we can finish off the proximal, then we can address all the extra bleeding if at all needed, and then we can shift down. So next we will be shifting actually somewhere in between, and we will finish off the intercostal. Then only we'll open the full aorta. So whenever we do this after the intercostal, when we're doing intercostal, visceral venous will be perfused by a pump. So this kind of sequential shifting reduces the amount of back bleeding from the intercostal, so it prevents the spinal cord ischemia. So this we just keep on shifting, and then reimplanting visceral and renals. So that's how we shift. First we do the proximal, then we do the intercostal, then visceral. So based on the extent we can continue. So this is about minimizing ischemia time. So in first method, we are trying to keep the ischemia to the spinal cord as much short as possible. There are three methods. One was shortest aortic clamp. Next is to give any distal perfusion techniques, and third is sequential clamping. So now coming to next method is optimization of the spinal cord perfusion. So main thing, the most important among whatever I said, the most important is the optimizing perfusion. So you should know that spinal perfusion is based on the difference between the CSF pressure and the mean arterial pressure and the CSF pressure. So whenever the mean arterial pressure is kept high and CSF pressure is kept low, the perfusion in the spinal cord increases. So as I said in the initially itself, whenever we clamp the aorta as much close, as much as much proximal near the arch, the pressure in say the CSF intracranial pressure increases. So automatically CSF pressure will be very high. So only way of bringing down the CSF pressure is by means of CSF drainage. And at the same time, we have to keep the mean arterial pressure high with the use of any vasopressors and all those agents, so that this difference should be maintained so that the perfusion inside the spinal cord increases. So the among all the methods, CSF drainage is the only method which has been scientifically proven to reduce the instance of spinal cord ischemia. So usually we after induction, our anesthetist usually put CSF drain. Some institute they follow one day prior they put the CSF drain. So initially itself we drain around 10-15 ml, and then before clamping also they drain around 10-15 ml, and then they keep measuring the pressure in the CSF drain intraoperatively. So we keep the pressure less than 10, and we continue to monitor this up to at least 24 to 48 hours. And after that, once the if patient is moving, we'll remove by 48 hours. If patient is having any paraplegia, we try to keep it for up to 72 hours. So the pressure should be maintained less than 10. If the pressure is high, then we will open and drain the CSF. And the one thing we should understand is we shouldn't drain more than 10 to 15 ml per hour, and not more than 150 ml per day. So if you drain more, then it will also cause cooling, and it can cause sudden death and all those things. So usually we don't prefer to drain more than 150 ml per day or 10 to 15 ml per hour. And CSF drain also carries, and definitely this is the most important rescue option when the patient has developed a delayed onset. If CSF drain is already not put, and CSF drain inserting a CSF drain will be treatment of choice of delayed onset, or if already CSF drain is there, the patient has developed any delayed onset paraplegia, you have to drain more CSF and keep the BP high. It will improve the delayed onset paraplegia. And definitely it carries the complication, especially the hematoma. So when we are so when spinal cord when we are putting the spinal cord drain, that some hematoma may happen, and especially when you are giving more heparin, the hematoma may per se can cause a paraplegia. So you shouldn't take CSF drain lightly. That's why many centers abroad they put CSF drain one day prior, and other problems are like cord injury and meningitis. So this is the most important method of optimizing spinal cord perfusion. Next is preserving spinal cord blood supply. So preservation is mainly by means of revascularization of the critical intercostal, and then avoiding backbleed from the spinal cord, which is called as steal. So as I already told, the one thing I forgot about telling is the Adam Kiwi. So the anterior spinal artery is it is very small as we go in the middle 1/3 of the spinal cord. So there the many radical branches of the intercostal comes and reforms the anterior spinal artery. One of the major radicular branch of the intercostal is called as the Adam Kiwis. So Adam Kiwis is usually can be found in between TA to L2 in most of the cases, but it can happen anywhere actually, but it is often found, maximum it is found in between TA to L2. So any major intercostal within that segment which we find intraoperative or preoperative, we have marked that has to be reimplanted. But routine reimplantation is controversial because two things have happened. One is even after reimplantation, patient may develop, patient have shown to be developing paraplegia. So then in TVAR, we close more than because of proximal distal landing zone, we are covering more intercostal, but still the incidence is less. So overall, some people say because of collateral network concept, with other collaterals are normal, we can close off all the intercostal without reimplantation. This was proposed by Randall and Green. So along with if you can combine I'll be showing about MME potential. If you can measure those things, we can avoid protein reimplantation. But what we prefer is in CT we see whichever intercostal which is big, and intraoperative that particular intercostal is not backbleeding, then it is not collateralized, so we reimplant. So practically that's what we follow. Any big intercostal which is not backbleeding, we try to reimplant. Then selective this is called routine reimplantation, like whichever is bigger we can do. Selective is means of motor evok potential, which I will be showing next. So there are various way of reimplantation. One is island method, where we take one patch of multiple intercostals, which mostly it is done in case of dissections where multiple intercostals will be back bleeding. Then we can use a loop method, or we can use a patch method. Like various methods are basically shown. See, advantage of these two methods are we can taking extra stitches are easy in this type. So this kind of island method, if there is any back extra, cut through is there, very difficult to take extra stitches. So that's why these two methods are there. And also we don't need to worry about the patency of this vessels. So what they have observed is, if these intercostals are flowing for first few 48 hours of the post surgery, once the cord edema settles, automatically the collateralization will take place. So it has to support only the initial few days. So no need to worry about long-term patency of this vessel. So and this kind of separate intercostal island also can be done. And next important method of preventing the spinal, preventing the spinal cord ischemia is avoiding stealing. So whenever you open the aorta, lot of intercostal will backbleed. So if we keep the suction over it, we will be sucking out whatever the remaining flow from the incisions within the spinal cord. So first itself, before opening, we try to clip the intercostal from behind. Or once we open, we put multiple Fogarties into the intercostal opening and then try to close it as early as possible. And you should never apply directly suction over this bleeding intercostal. You should be very careful. And then next method is how to detect early during surgery. So most important method is we have a evoked potential. We have motor evoked potential and somatosensory evoked potential, and NIRS is also some ways we can detect early subcutaneous, subcutaneous ischemia. So there are advantage of why we use this. First of all, it shows whether ischemia is happening or not. If at all is happening, at which level when we clamp it is happening. In that case, we can reimplant those particular vessels. So there are two types, basically somatosensory and then motor evoked. Somatosensory is basically what they do is they will give a electrical stimulus in the peroneal periphery and then try to get those signals from the scalp. So it basically what it does is we are giving in the hand as well as in the legs, they'll give some stimulus, and then they try to see the amplitude in the scalp. If there is more than 50% fall when they're clamping, then maybe that is causing ischemia. But most important problem with somatosensory is it is detecting only the posterior sensory column. So, but we are more worried about the anterior column. So that's why it is not much used. Most commonly or most widely studied is the motor evoked potential. So it is more specific for anterior spinal artery territory. So what they do is they give a transcranial impulse. They give an impulse from the electrodes is kept in the scalp as well as in the hand and the leg. So in the hand they keep it over the thenar eminence. Other one is in the over the near the shin, and they see the give the electrical stimulus and see the amplitude in these vessels, in this muscles. So if there is, and then they do the sequential clamping, and in which level the sequential clamping the amplitude decreases. So probably that level there is a major intercostal is there that has to be reimplanted. That has to be reimplanted. So that's how we identify. And main problem is if the patient is on, when during anesthesia they give a neuromuscular blockade, this may interfere with it. So we have to reduce the dose of neostigmine during this procedure, during this motor evok. Both these are not used in our institute. We usually go by CT scan imaging and intra-op assessment. If CT scan shows any major intercostal or any which is not backbleeding intraoperatively, then we reimplant those intercostals. And last is the increase in tolerance to the ischemia. So these are basically two methods are there. One is hypothermia and other is pharmacological. So generally any temperature fall increases the metabolism of that particular organs. For example, enoplegia, how we give, and for cooling the brain in case of circulatory errors, everything. So any systemic hypothermia will reduce the metabolism by around each degree is around 10 to 5 to 7% decrease in metabolism. So same thing we follow for spinal cord also. So we bring the temperature up to 32 during surgery. So usually it is called temperature drift. Drift means we are not intentionally making the temperature to fall as you during the surgery. As you start doing the surgery, when you open both the thorax and the abdomen, automatically the temperature will fall from whatever we started. We usually start with 35, 36, and it will keep on falling, and we maintain it around 32. Why particularly 32 is beyond 32, the high chance of fibrillation is there. Heart may go on for fibrillation. That's why we try to mention around maintain around 32. So that will increase the tolerance of the spinal cord to ischemia. Other methods like circulatory arrest, some people have causally they have mentioned about selective epidural cooling. So they put one in the CSF drain and one is in the epidural drain, and through that they give a cold saline for cooling the spinal cord alone. Like how we give renoplegia, they are giving a cold saline to the spinal cord, but only the own center does. We have never tried those things. We generally go for systemic hypothermia up to 32 degrees Celsius. And last is the pharmacological. There are various, okay, this is about hypothermia. So as I said, most commonly is up to 32 degrees Celsius we try. And what we do is called as a passive drifting. So without any, actively we don't use any other methods to bring down. Next is actively we can do using a pump, either using when you go on pump, it is very easy to bring the temperature up and down. So deep fast is bringing up to 18 degrees Celsius is usually done only when in case of when there is no proximal clamp space. So these are the things. And this is selective cooling. So we have two needles, one in the subarachnoid, one in the epidural space, and they keep giving the cold saline. So pharmacological adjunct what we routinely use is the steroids. So steroids should be shown to increase the reduce the tolerance to increase the tolerance to ischemia, mainly in the trauma. So we use the same trauma protocol. What we do is we give on induction 30 milligram per kg of steroid. Like usually it comes around to 2 gram, 1.5 to 2 gram of methylprednisolone stat, followed by 5.4 milligram per kg per hour infusion. So that usually this is given for 24 hours, and that has been shown to reduce the spinal cord ischemia, mainly cord edema, mainly in the acute trauma. So same thing we also follow. Other medicines they use is the other than that, so many medicines, so many other agents have been shown. Thiopentone, mannitol. Mannitol mainly it causes the free radical scavenging. So these are the other medicines that has been used, but most commonly used is the steroids. And coming to specifically about TVAR, TVAR, as I said, the ischemia, I mean, spinal cord ischemia is less compared to open surgery, mainly because we are avoiding cross clamp, but still it happens. There are other theories, unlike where open surgery, where the main inciting factor is the cross clamp followed by ischemia and reperfusion. In TIVA, there is no per se ischemia reperfusion. There are other theories have been given. First is one is the thrombus, like when you put TIVA, the stent is pushing the wall thrombus into the particular vessel that is causing ischemia. Second is as I said earlier, we are closing, I mean, we are extending above and below by 3 centimeters for landing zone. So we are closing more intercostals than what we close in the open repair. So these are some of the theories, but definitely the ischemia will be more when you have covering entire DTA, especially when you are not going to give a supply bypass. So these are the various risk factors when there is more than 20 coverage or previous aortic aneurysm repair or left subclavian coverage, especially along with DTA. So these are the, like whenever the collaterals are blocked, subclavian or hypogastric or lumbars are blocked, it will definitely increase the risk of spinal cord ischemia. So even though, as I said, the paraplegia, the causation is anatomic. So we know that everything starts with we are closing off the intercostal, but the prevention of spinal cord is predominantly not only non-anatomic, but is more of physiologic. So we have to know it is simply by reimplanting the intercostal alone, we may not be able to prevent the spinal cord. So we have to use all the adjuncts, as I told. And even after all this, it can still happen. So completely it is not preventable, and once it happens, we don't have much treatment options. Either unless it is only a paraparesis, some CSF drain and the BP high can help. Otherwise, once the paraplegia happens, mostly nothing much we can do, and it usually patient ends up with mortality. Thank you.